Hello, this is Kay Afchi, and I am recording the lecture for Learning Plan number 9 on nursing care of individuals with alterations in the neurovascular system. We're going to go over some anatomy and physiology real briefly. First of all, we'll start with the central nervous system. Central nervous system is made up of the brain and the spinal cord. Surrounding the brain and the spinal cord are the protective coverings known as meninges. There are three different meninges, or three different layers. The innermost layer is the pia mater, and that's a thin, very vascular layer that surrounds the brain and the spinal cord, so that's in the innermost layer. Then we have the arachnoid meninge, which is in the middle, and the dura mater, which is the outside covering, which is extremely leathery. And those three layers surround the spinal cord and the brain. Next, within the brain are open areas called ventricles. And in this area, the cerebrospinal fluid is manufactured. Another service, so to speak, of the ventricles is that it allows the brain to be a lighter weight because it does have these open spaces inside of it. So then the brain and the contents of the head is not quite so heavy. After the ventricles, then we have the cerebrospinal fluid. The function of the cerebrospinal fluid within or outside the brain and the spinal cord is that it provides protection. Cerebrospinal fluid should be clear and colorless. If it would be cloudy, that could be a sign of an infection. The spinal cord itself is composed of ascending tracts and descending nerve tracts. Ascending tracts are sensory. Descending tracts are motor function. And then the reflex arc is just a more simple conduction pathway. It utilizes a receptor or sensory neuron centered within the spinal cord itself and a motor neuron located in the effector skeletal muscle. So if a stimulus travels from the sensory receptor through the spinal cord and back to the effector, causing like a reflex motion or a pull-away motion, it's kind of like a shortcut so that the sensory information doesn't have to travel all the way up to the brain, be interpreted, and then the motor message needs to be sent down to the extremity. It's more of a shortcut within the spinal cord. So if you touch something hot, you pull your hand away right away. You don't have to wait a minute until your brain recognizes that what's going on. So that's called a reflex arc. The peripheral nervous system also has afferent and efferent division. Again, it's part of the reflex arc, even though the reflex arc is within the spinal cord. Then we have cranial and spinal nerves and the sympathetic and parasympathetic nervous system. We talked about the reflex arc already. The cranial and spinal nerves are part of the somatic subsystem and respond to changes in the outside world. These nerves initiate voluntary action, so this is often called the voluntary system. The autonomic nervous system is activated or is active in maintaining internal body balance, homeostasis, and is involuntary in its actions. The autonomic system is divided into sympathetic and the parasympathetic nerves. The sympathetic mobilizes energy to initiate changes aimed at maintaining or restoring homeostasis, and parasympathetic nerves, which are aimed more towards conserving and restoring energy, also are used to maintain homeostasis. So the sympathetic nervous system is more the fight and flight response, whereas the parasympathetic system is more related to returning to the resting state. Here we have the structure of the neuron, which is a component of the nervous system. The finger-like extensions that you see on the left-hand side of the neuron are dendrites. Those receive stimulation, sensory, pick up sensory information, which is transmitted then through the cell body and then through the axon. The axon is covered by a myelin sheath, which facilitates the traveling speed of the impulse, and then the impulse will then travel either to the brain, or it will travel, in the case of a motor neuron, it will travel down to a muscle. If you have difficulty in remembering the parts of the neuron, if you think of your hand and your arm, the fingers would be the dendrites that would pick up the sensory information. The information or impulse would then travel through the cell body and then up through the axon. In this slide you see the different functions and lobes of the cerebrum of the brain. You don't have to necessarily remember all these different functions and their locations, but I use this figure just to show you the importance of being able to determine where damage can occur as exhibited by the types of symptoms that the patient may exhibit. So let's say if the patient has a head injury in their occipital lobe, chances are they're going to experience visual problems. If they experience brain damage or some stroke or something like that in their parietal lobe, then they may have some problems with motor or sensory function. So it's really important when you're doing your neurocheck to document any changes, because that will help locate any areas of brain damage. The next picture you see here is kind of a picture of how the reflex arc works. The receptor nerve picks up the information, like this person here is stepping on a nail, transmits it quickly up to the spinal cord, where there's an interneuron type of junction that shortcuts that information and sends then a response, such as drawing your foot back up off of that nail by sending it down to a cell body ganglion, which then stimulates the effector muscle to withdraw the foot. Okay, so central nervous system protection. The bones of the skull and the vertebral column form the outer layer of protection for the brain and the spinal cord. The meninges are the protective membranes that cover the brain and are continuous with the membranes covering the spinal cord. When in a state of polarization, neurons have the capacity to become excited or stimulated and have the ability to conduct the stimulus along the nerve pathways. A stimulus is a physical, chemical, or electrical event that changes the cell membrane and initiates conduction of the stimulus as an electrical impulse along the nerve pathway. The stimulus travels from one neuron to another across a synapse, or space between two neurons. The neurotransmitter secreted by the neuron is necessary for transmission of impulses across the synapse. The Schwann cells form myelin sheaths that wrap up and around the axons of the peripheral nervous system. Once destroyed, cells in the brain cannot be replaced. But in the peripheral nervous system, the Schwann cells can regenerate. Neurons are very sensitive to oxygen and die quickly when deprived of oxygen. The brain's neurons cannot survive anoxia for more than 4 to 6 minutes. Some age-related changes. As a person grows older, they have a loss of neurons and have decreased functioning of the neurons. There may be a decreased blood flow to the brain. Body homeostasis is much more difficult to maintain or to regain. Short-term memory is affected, and there's a decreased secretion of the neurotransmitters norepinephrine and dopamine. Posterior root nerve fibers and sympathetic nerve fibers decline, and in the peripheral nervous system, the motor nerve fibers and the myelin sheath degenerate with advancing age. Reflexes may be diminished or absent, and pupils decrease in their size, so which is important to remember if you're going to be doing a pupil check, a Perla check on an older person. Their pupils are going to be decreased in size normally. Other changes: older persons may need more time to process questions, solve problems, or learn new information, and using the brain and keeping it active promotes continued intellectual function in the healthy elderly. The evaluation of neurostatus, cranial nerve check is part of the neurological evaluation. For the most part, the nurse practitioners usually will do cranial nerve checks. It's not usually something that we'll do as a standard check for as a nursing assessment. But we do check coordination and balance. And to do this, we may do a Romberg's test, where the patient is asked to stand with her feet together and close her eyes. If the sense of balance is normal, a steady posture will be maintained, and there will not be swaying from side to side. Then ask the patient to walk across the room and assess their gait. Then next, stand in front of the patient, hold up a finger and ask the patient to touch your finger and then their nose. Move your finger to different locations in front of the patient, and this test checks both the ability to follow directions and the patient's coordination. A neuromuscular functioning test is where groups of large muscles are tested for strength and coordination. So you evaluate the patient's gait while walking. You may evaluate their hand grip strength and their arm and leg strength as the patient pushes against resistance. And then the reflex that we check is known as the Babinski's reflex, where if you kind of scrape the bottom of the patient's foot, maybe with your finger, you'll notice that their toes will curl under. In a newborn, you would see the reflex where the toes would fan out, but in a child or older adult, you would see the reflex being that their toes would curl under. Okay, neurological disorders we're going to talk about later. The slide you see here is just a group activity that we do in the face-to-face class. Okay, signs and symptoms of increased intracranial pressure. Changes in level of consciousness is the earliest change seen in increasing intracranial pressure. More later signs and symptoms would be the pupils would become fixed and dilated. Altered motor function may be observed, such as hemiparesis or hemiplegia. You may note abnormal posturing, such as decorticate or decerebrate positioning. The patient may experience loss of temperature control and may also exhibit alterations in respiratory pattern. Here's a picture of decorticate and decerebrate posturing. So decorticate posturing is the picture on the top where the person's arms are flexed and they have a plantar flexion and their legs are internally rotated. For decerebrate posturing, there's plantar flexion, but their arms are extended, their hands are flexed, and their arms are pronated out. neither one of these posturings is a good for the patients that experience these types of posturing. It's a pretty serious symptom. Prognosis is pretty poor when you see patients in such a position. Okay, so nursing management. First of all, we would do a nursing assessment. We would get a patient history, find out what their symptoms are, how long they've had them. We would do a physical assessment of check their vital signs, their mental functioning, and their level of consciousness. We would do a neurologic and neuromuscular check as well, a pupillary check, and also a neuro check. So pupil check pupils are equal and reactive to light and accommodation. We would check their hand grasp, their movement, their sensation in their extremities, and that type of thing. Other diagnostic tests that are done for neurological issues. One test that we do is a lumbar puncture. The lumbar puncture or spinal tap measures the cerebrospinal fluid pressure within the spinal cord. We can also get samples and check the fluid for clarity, check for presence of glucose, protein, or white blood cells. The patient may experience a headache after the procedure due to leaking cerebrospinal fluid, and that can be treated by the anesthetist doing a blood patch where they draw some blood off and they insert it into the spinal column to block that leakage. In this picture, you see how the patient is positioned for their spinal or their lumbar puncture. The patient is curled to their side in a fetal position. The physician will numb the area, and then they will insert a spinal needle into the area between the L4 and the L5. They want to go to that area because the spinal cord does not extend down to the L4 or L5, so we don't have to worry about accidentally puncturing the spinal cord. So we insert the spinal needle. Doctor then will attach the needle to a measuring device that will measure their pressure of the cerebrospinal fluid in the spinal column, and they can also draw off specimens to be sent to lab and assess the clarity and color of the CSF. Another test that can be done is the electroencephalography test, or EEG. What that does is it traces the electrical activity of the brain cells and is often used in diagnosing seizures. Here's a picture of a patient having an EEG. Things to remember about this would be to make sure not to give the patient any kind of sedatives prior to the exam or sleeping meds, because that could impact the results of the exam. Oftentimes we'll have the patient wake up early in the morning, and then when they go down for the test, it's preferred that the patients actually can be sleeping, and then they'll be able to get a good baseline of brain activity without a lot of interference from the patient being awake and that type of thing. Okay, another test, is the electromyography test. The test checks the response of the peripheral, motor, and sensory nerves to electrical stimuli. So it's a good way of checking the peripheral nervous system. Radiologic studies, a brain scan can be done. The patient is injected with radioactive isotope intravenously, and then that isotope will highlight areas. They do the brain scan to check for brain abscesses, tumors, or in some cases hemorrhage. Another radiologic test is the cerebral angiography and digital subtraction angiography. Provides Images of the cerebral, carotid, and vertebral blood vessels. Then we have the computed tomography or CT scan, which is done to evaluate trauma, tumors, or check for hemorrhage. Here you see an example of CT scan. It can kind of give you an indication or picture of slices of the brain, so you can determine if there's any tumor or hemorrhage going on. Also, you can do a magnetic resonance imaging procedure, which uses radio frequency waves and allows measurement of flow through blood vessels. We need to make sure that the patient has no metal prosthesis, a pacemaker, or metal implants that can be, which would be contraindicated due to the magnetic field that's used. And here you see an example of an MRI. You can kind of get a good indication of like the soft tissues that will show up with an MRI, and some of the blood flow as well. Some of the common neurological problems that you will see as far as nursing diagnosis goes: ineffective breathing pattern, impaired mobility, self-care deficit, dysphagia, incontinence, confusion, aphasia, and ineffective family coping. Many of these nursing diagnoses you've probably become familiar with, but I did just want to mention with aphasia. Aphasia is a defect in the ability to express oneself in speech or writing, or it can be an inability to comprehend the spoken or written language. Aphasia is caused by a disease or injury of the brain center that controls language, comprehension, and expression. Aphasia can be receptive, expressive, or global. The person with receptive aphasia has difficulty interpreting communications to her in either spoken or written form. In expressive aphasia, the person has difficulty expressing herself in speech or in writing. And in global aphasia, the person has a combination of both receptive and expressive aphasia. The aphasia can vary in degree and in type of deficit. So it's important, to evaluate the patient's ability to communicate as well as their ability to understand what's communicated to them. A speech therapist needs to be consulted if a patient has aphasia. They'll be taking care of assisting the patient in adapting or improving that condition. Okay, let's take a look at this question. While performing an initial assessment, the nurse notes that the patient provides inappropriate responses to verbal communication. When showing the patient the key and asking, "What is this?" the response is R-O. This clinical finding is referred to as dysphagia, expressive aphasia, dysarthria, or receptive aphasia. So take a minute and look at the symptoms and decide what type of problem this patient has. If you picked the letter B, expressive aphasia, you would be correct, because the patient isn't able to speak or express themselves. Dysarthria is a condition where the patient's speech is slurred, but you still be able to understand them. And receptive aphasia is when the patient isn't able to understand what the nurse is saying to them. Okay, the next question. When giving instructions to a patient with some dysphagia, further teaching is needed if the patient states, "I must sit upright when I eat. I can watch my crime show on TV while I eat. I should stay upright after eating for at least 30 minutes, and I should be calm and unhurried when eating. So what statement would indicate the need for further teaching? And the answer in this case would be, I can watch my crime show on TV while I eat, because the patient with dysphagia needs to be concentrating on what they're doing. They really shouldn't be using distraction. They should be concentrating on their swallowing. While assisting the patient with feeding, the nurse describes every step in meal preparation in simple language. This is referred to as parallel talk, self-talk, expansion, or modeling. The answer to this question is parallel talk. When you're working with a patient and you want to try and help them, again, learn how to understand what is being said, if the nurse describes every step of what they're doing, that's described as parallel talk, and it helps the patient to understand and learn again what the words mean. With an open hand, the nurse presses over the flaccid bladder of a patient. When questioned regarding the nursing action, an appropriate response would be: A, the technique increases the muscle tone of the bladder. B, the maneuver facilitates removal of urinary sediments. C, the technique assists with complete bladder emptying. And D, the technique reduces the incidence of bladder irritation. And this would be used, this type of maneuver would be used if a patient was not able to, or was incontinent, wasn't able to voluntarily void. So the answer to this particular question is that this technique assists with complete bladder emptying because of the pressure that the nurse uses on the patient's bladder.